Hello and welcome to the video. Today I'm going to be talking about understanding the inflammatory response to infection in terms of the underlying pathophysiology and the clinical application. So without further ado, let's get right into it. The inflammatory response starts with an antigenic stimulus, which is generally some component of a pathogen, such as a bacterial, viral, or fungal pathogen. These foreign antigens make their way into the body, such as under the skin, the respiratory tract, or the urinary tract, where they can be detected by cells of the innate immune system, such as neutrophils, macrophages, and dendritic cells, which can process the antigen and present them to T cells to activate the adaptive immune response. Upon detection of a foreign antigen by these innate cells, a number of pro-inflammatory cytokines are produced, namely TNF, IL-6, and IL-1. These cytokines all have overlapping actions which drive the clinical manifestations that are seen in a patient who has an infection or sepsis. For example, TNF or tumor necrosis factor makes its way to the brain, specifically the hypothalamus, which normally regulates body temperature. The action of TNF here is to try and create a fever by increasing the body's baseline temperature. Upon shifting the body's baseline temperature upwards to generate the fever, there is a disconnect between the body's perceived temperature and the body's actual temperature, and this often leads to the symptom of having chills, where the patient feels very cold. One of the other classic symptoms is that of rigors, where the patient undergoes rapid movements and muscle contractions, which is able to generate heat to increase the body temperature and lead to a fever. Once the elevated temperature has been reached and the patient is having a fever, the body's natural response is to try and cool itself down, and it does that by generating a lot of sweat, and that's why patients have sweats after a fever. So typically, patients will go through these symptoms of having chills, rigors, and sweats, and their temperature will often be elevated over 38.0 degrees, which is generally the accepted temperature for which above this we consider it a significant fever. One of the main functions of IL-6 is to stimulate the liver to produce a number of acute phase reactant proteins, of which one that we commonly monitor is that of the C-Reactive Protein, or CRP. The CRP is often elevated in infections, going from a normal range of less than about 5 milligrams per liter up to about several hundred in cases of severe sepsis. There are several other so-called acute phase reactants which can be either positive, which increase, or negative, which decrease. CRP is a positive acute phase reactant as its levels increase in inflammation, with other examples including procalcitonin, which is sometimes also used as a marker of infection like C-reactive protein, as well as ferritin, fibrinogen, and even haptoglobin, which is used as a marker for hemolysis. Negative acute phase reactants that we can measure include that of albumin and transferrin. At this point, I might mention that the acute phase reaction of having an elevation in ferritin and a reduction in transferrin is thought to be an evolutionary adaptation in order to try and sequester iron away from the blood and into the liver, hence the rise in ferritin, and a reduction in transferrin production to allow less mobilization of iron. Iron is an important resource for bacteria as it forms an important component of their electron transport chain in terms of the iron sulfur clusters, and thus by sequestering away iron into the liver, you're essentially starving any bacteria that are in the blood of iron, which makes it difficult for these bacteria to survive. IL-1 is one of the main cytokines which drives an enhanced innate response, which leads to more innate cells homing to the site of infection. The The characteristic pattern that is seen on a full blood count in a patient with an infection is that of neutrophilia, because neutrophils, which normally attach to the walls of vessels, downregulate selectins, which are adhesion molecules on immune cells, which therefore leads to an increase in the number of circulating neutrophils in the blood to allow the neutrophils to then get to the site of infection and carry out its role in destroying the foreign pathogen. A similar process occurs for monocytes, which also increase in number as they circulate around the body to try and home towards the site of infection. And these monocytes, upon reaching the site of infection, then differentiate into macrophages and dendritic cells to help aid the innate response. The innate antigen-presenting cells, namely the dendritic cells, but also the macrophages, can interact with T helper cells to then lead to a delayed adaptive response. The two main arms of the adaptive immune response includes that of a B cell or humoral-mediated antibody response, where B cells become activated into plasma cells and start secreting antibodies with specificity to the antigenic stimulus. These antibodies can then circulate in the blood and bind to the antigens of the foreign pathogens and help aid phagocytosis of the foreign pathogens by innate cells such as macrophages. The other important arm of the adaptive immune system is that of the T cells, where there are CD8 or cytotoxic T cells, which play an important role in clearing virally infected cells, and the CD4 or T helper cells, which can further differentiate into specific subtypes depending on the cytokine milieu at the time. Although we now recognize that there are many different T helper cell subsets, for simplicity, there are two main T helper cell subsets, including Th1, which is driven by interleukin 12 and leads to enhanced production of interferon gamma and TNF alpha, which promotes cell-mediated immunity and enhances the innate response. The other major T helper subset is that of the Th2 cells, which are driven by interleukin 4 and promote humoral or antibody-mediated immunity, which are important in clearing extracellular pathogens via promoting phagocytosis, as mentioned previously. This is in contrast to the cell-mediated immunity promoted by Th1 cells, which play an important role in clearing intracellular bacteria and virally infected cells. And as an early part of the adaptive response, the lymphocytes can home to the site of infection, which leads to lymphopenia. Another reason for lymphopenia in the late part of the adaptive response is when there is T-cell exhaustion and apoptosis of T-cells that increase in population after the initial antigen-presenting cell T-cell interaction. And so to very quickly summarize the function of the immune response, the antigenic stimulus or danger or pathogen-associated molecular patterns are recognized by innate cells via pattern recognition receptors, which include the toll-like receptors and Rig-like receptors, which leads to the production of key pro-inflammatory cytokines which enhance the innate response to home towards the site of infection. These innate antigen-presenting cells then interact with T cells at the level of the local lymph nodes, which then interact with B cells in germinal centers to then become activated and become plasma cells to then secrete antibodies as part of an adaptive immune response. The other important arm of the adaptive immune response is that of the cytotoxic T cells, which are important in viral infections, and the differentiation of T helper cells into different T helper cell subsets, of which Th2 leads to an enhanced humoral antibody-mediated response, and the Th1 subset leads to an enhanced cell-mediated immunity or an enhanced innate immune response. Altogether, this leads to an effective first wave and second wave of defense to ultimately clear the infection. And because of the actions of these components of the immune response, you get a number of characteristic presenting features which you see in a patient with an infection, namely a fever with chills, rigors and sweats, an elevated C-reactive protein, and the classic pattern that you see on the full blood count differential of a neutrophilia, a monocytosis, and a lymphopenia. An infection also leads to significant physiologic sympathetic activation and cortisol elevation, which leads to the classic presentation of a tachycardia and systemic vasodilation, which when severe can lead to hypotension as well. This will lead to decreased delivery of oxygen to organs and therefore an increased reliance on anaerobic respiration, which will drive the amount of blood lactate higher. So in the setting of severe hypotension, which is often defined as a systolic blood pressure of less than 90 or mean arterial pressure of less than 65, along with a lactate level higher than 2 millimoles per liter in the setting of signs of sepsis, we call this clinical syndrome septic shock, which when severe will need vasopressor therapy. At this point, it's important to note that this antigenic stimulus can both be extracellular or intracellular, and that while most commonly an infectious pathogen is the cause of the antigenic stimulus that drives the inflammatory response, there are a few other things that can also act as antigenic stimuli. These can include self-antigens or autoantigens, which can be recognized by autoreactive immune cells and thus drive an inflammatory response in autoimmune diseases. The antigenic stimulus can also come from tumor antigens, which can drive an inflammatory response in the setting of malignancy. Other antigenic stimuli include things like gout crystals, which can lead to the formation of inflammasomes to drive the production of IL-1 and hence lead to an inflammatory response, not dissimilar to that in infection. There are also genetic disorders known as periodic fever syndromes, of which the most well known is probably FMF or familial Mediterranean fever, where there is a constitutively active inflammasome pathway, which therefore leads to the patient presenting with all of these features, but without evidence of an underlying infection. And so while infection is the most common and is usually your primary differential diagnosis, it's important to consider other differential diagnoses in the setting of a fever. At this point, I should also mention that it is not uncommon to see a reactive or secondary thrombocytosis with an elevated platelet count in the setting of sepsis or inflammation. The mechanism of this is not clear and is not a consistent finding, which is why I have not put this in the diagram. But the mechanism is thought to be centered around IL-6 stimulation or the production of thrombopoietin acting like an acute phase reactant, which stimulates the production of platelets and hence thrombocytosis in the setting of an inflammatory response, which can often be prolonged. So now that we have some understanding of the pathophysiology of the innate response to infection, we can now move on to see how we can detect these changes clinically when we're looking at blood tests. Here is a graph I've made up showing the neutrophils, lymphocytes, and CRP, which are commonly seen from a full blood count and biochemistry respectively, in a patient who has an infection. And so, assuming all of these levels are at baseline, which is considered normal, after an infection, you can see the first thing to rise is usually the neutrophil count, along with a decrease in the lymphocyte count. The CRP will also start to rise, but this is often a little bit later. This is because neutrophils, and to some extent lymphocytes as well, upon receiving the pro-inflammatory cytokine signal, mobilize to the site of infection early on in the innate immune response, whereas CRP production is reliant on interleukin-6, which has to be detected by the liver to then stimulate the production and release of C-reactive protein into the blood, which is often a more delayed process. This is why it is not uncommon to see what is known as a CRP lag, in that the patients will be febrile early on, but if they present less than, say, 12 hours after their fever, their C-reactive protein is often still low, but then will spike in the following 24 hours. Another clinically useful thing to do is to always look at the ratio between the neutrophils and lymphocytes, known as the neutrophil-lymphocyte ratio, or NLR. Usually in infections or any severe physiological stress, the NLR will increase, which you can see is shown by this increasing gap. A neutrophil-lymphocyte ratio of more than about 9 is quite specific for an infective cause, whereas a neutrophil-lymphocyte ratio of less than about 4 is more specific for an autoimmune flare. In terms of the response to infectious pathogens, for bacterial infections, there tends to be a predominant neutrophilia, because it is the neutrophils that tend to fight off the bacterial infections. In contrast, in viral infections, it tends to be the lymphocytes, more specifically the CD8 T cells, which are involved in clearing viral infected cells. And hence the predominant change is more a often isolated lymphopenia. Now, what happens to these parameters after we initiate successful treatment of the infection, which is depicted by this orange line here? Well, as the treatment successfully clears the antigenic stimulus, we then lose the production of the pro-inflammatory cytokine, which will therefore lead to a resolution of the neutrophilia and the lymphopenia. An improving neutrophil-lymphocyte ratio is often one of the earliest and best markers of treatment response. Because the synthesis and release of CRP is relatively delayed, it is not uncommon to see a lag in the peak of the CRP, where the CRP is still going up while the neutrophils and lymphocytes are already normalizing. This is why it is better to look at the neutrophil-lymphocyte ratio reducing as an earlier marker for response to treatment, as opposed to looking at the CRP alone. However, a downtrending CRP, or more specifically a halving of the CRP roughly every 24 hours, is a really strong indicator of treatment response. This is because the antigenic stimulus drives the production of pro-inflammatory cytokines, specifically interleukin-6, which leads to the production of CRP. Now, as long as that antigenic stimulus is present, there will continue to be a signal for the production of CRP, and so the CRP will reach a peak and will stay high for as long as the antigen is still present. This is why for some patients with what is known as a pyrexia of unknown origin, or PUO, can have continuous sustained fevers for prolonged periods of time, such as weeks, and have a correspondingly persistently elevated CRP, often in the hundreds. However, once the antigenic stimulus has been identified and adequately treated, so for example, the source of infection has been identified and the appropriate antibiotics have been administered, the clearance of the bacteria and hence the antigenic stimulus will lead to a loss of the signal, specifically the IL-6, to the liver to produce CRP. And so the CRP production will essentially turn off. Once CRP production has been turned off, it will then clear itself, just like any other drug, where it will break down in the blood, and its clearance is also affected by the renal function. The half-life of CRP is around 19 hours, which for simplicity's sake we can round to 1 day. And so once the antigenic stimulus has been cleared and CRP production has been turned off, the CRP level will then fall at a rate of about half every day, in keeping with its pharmacokinetic profile. And so if you are monitoring the treatment response for a patient and you're not sure if they're actually getting better from the antibiotics, but you see a CRP halving over a day, so for example going from 240 to 120, you can be pretty certain that whatever antigenic stimulus was driving the production of CRP to that peak of 240 has been cleared, and so the remaining CRP in the blood will also be cleared in line with its pharmacokinetics. However, say the CRP goes down from 240 to only about 200 or 180, or only goes down by a quarter as opposed to a half, that would suggest that there is incomplete clearance of the antigenic stimulus. And so while there may still be a treatment response, this is not a complete treatment response. And so it is not as reassuring as seeing a halving of the CRP. At this point, I might talk about what CRP actually is and its function. It was named CRP because it seemed to have specificity and precipitated with this C polysaccharide of Streptococcus pneumoniae. It has an important physiological function in fighting bacterial infections, in that the CRP acts as an opsonin where it can bind to the cell wall of bacteria with high specificity to pneumococcus and activate the classical complement system, which leads to destruction of the bacterium. It can also aid phagocytosis and hence the clearance of the bacteria by macrophages. The intensity of the CRP response can also give a clue to the underlying etiology, as a very high CRP, around 400, would be consistent with something like vasculitis, which can induce an intense inflammatory response, or a pneumococcal infection, typically in the setting of a pneumonia, where it tends to stimulate a high level of CRP production in the setting of its antigenic specificity. And that brings us to the end of this video. I hope you now have a better understanding of the inflammatory response to infection. Here are the key take-home messages for your review as discussed throughout this video. If you like this content, please leave a like, comment, and subscribe to the channel. All the best.